Well, Dr. Chapman, thank you so much for finding the time to talk with me, and congratulations. You
Thank
pulled
you,
it
Paul.
off.
Thank you so much.
So it took, let's see, uh, you took the job in March 2022, and you had 14 months before CCSG. How'd you do it?
Uh, an enormous amount of hard work. Um, First of all, so a lot of time. I think that, the bringing the team together was really important. So really, utilizing the skills of, the entire team to do this. I spent a lot of time learning, about the CCSG from the FOA to make sure that I was really well versed in, all the merit descriptors and what was being asked of us. So that was really important to do. And so I think that, it amounts to, recognizing that we had a short runway. And so it's really leadership and teamwork that were the key elements to this. The other point that was pretty important came from the external advisory board. And this was before I became the permanent director. So I took over as the interim director in June of 2021. And one of the first meetings with the EAB, it was made very clear to me that that it was important to be pushing the center forward, even though I was in an interim role, because you never know what happens with recruitment, and we did not want to lose additional time. So although, we could not begin writing, for example, a strategic plan or really, planning for the grant submission, I still felt that it was important to push the center forward from the standpoint of recruitment, retention, building the clinical trials office, trying to build up our population science efforts. So there were some additional pieces that we focused on even in that interim period of time.
So basically, the reason you could do it is that you had the team in place, and there's no way you could have done that and replaced the team probably in 14 months.
Also, I mean, the thing that really helped me was that, I knew the entire team very well. Having been at Jefferson literally my whole career since 1994. And, all of the people that were in place, I had, interacted with in various different, levels prior to becoming the interim director. And then as the interim director, in a lot more space. So, I was really able to work closely with all of the team members that were in place as we were moving the center forward. Again, since I didn't know that I was going to be the permanent director, I couldn't really do the things that you would do specifically, for strategic planning and for development of the grant. That really wasn't because if a new director came in, that would all potentially change. But the real advantage I had was I was already in the seat as the interim and I knew the team very well.
Hmm. Hmm. Well, Karen built up quite a team, and you were on it.
That's also true. I had some experience, with being a program leader, prior to accepting the position as the interim director. So I started to work with the other program leads for the cancer risk and control program. So I was already involved in that piece, which was one of the areas that we felt really required a lot of attention.
What was the difference for you between cancer center designation and comprehensive cancer center designation? Where was the lift heaviest?
I think that really the development of the cancer risk and control program was one really key piece. It
Hmm.
gave a home to all of the population science across the consortium. I think the second piece that was really important was redefining the consortium and really building out a much closer relationship with the scientists at both TJU and Drexel, creating, deeper collaborations, opportunities for projects. So I think a lot of it centered around strengthening the consortium as well. Um, those were probably, I mean, there's always the piece about retention and recruitment, which are really important, especially at a time, so critical as, trying to get the grant together.
Mhm. Can we talk about the consortium? How does that work? It's you and Drexel, and how does that function? Is it who has what? How?
So, I mean, as you know, the grant is held by by Thomas Jefferson University. So it's a research grant, right? It is not there's no clinical component to the consortium. It is solely a research consortium. And the way that we structured it was that there is both an integration committee, which is responsible for the day-to-day operations, if you will, of the consortium. And then there's an oversight committee, which is the leadership decision-making body, of the consortium. And that includes leadership from both TJU and Drexel, and I chair that oversight committee.
But there's a 5 and 7 rule. That wasn't a problem, right?
You mean in terms of the number of grants and the number of
Yeah.
investigators? Yeah, we that was not the issue. What we wanted to really deepen was just, first of all, we thought that there was additional talent and we wanted that talent to collaborate. So we thought there was additional talent at both TJU and at Drexel and really bringing them all together. Additional members, that came from Drexel. And I think the opportunity to strengthen the collaborative science was really key, as well as the course.
I think if I remember correctly, one of the problems you've tried. I mean, Karen tried to go after the comprehensive designation, and one of the problems you ran into was population sciences program was not strong enough. It wasn't mature enough. It just hadn't. You just needed to do one more cycle. Is that? Do I remember this correctly, or am I?
Not exactly, because the way that yes, but not exactly.
Okay.
So let me just sort of clarify for you. So in the previous submission, there was no program dedicated to population science. The population scientists were um, spread across the 5 programs, in the center. And what happened was that it was a different, it was a sort of a novel mechanism as opposed to, having a dedicated population science program, which we've named the Cancer Risk and Control Program. And so um, this was a different mechanism, and I think that the reviewers felt that there was not adequate funding within across the different programs. There was not adequate distribution and integration of population science in the 5 scientific programs at the time. And so after we received our reviews from the 2017 submission, we restructured the programs. And so we took the disease-based programs and combined them into a mechanism-based program. So we have, 3 mechanism-based programs and then the cancer risk and control program. And so that we restructured the scientific programs to better enable the population scientists to function. And it showed up in terms of the amount of grant funding, the amount of publications, and also their interaction with the other members within the other programs. So it
Mhm.
actually enhanced the relationships.
Were you able to, did you need to recruit for that? Or did you have everybody pretty much?
There were a few recruits, in population science. But that was definitely a place in which it was clear to us that, that we wanted to enhance and frankly still do.
Does it matter that you're a geriatric oncologist? How did it change the institution?
So I think that there's a couple of points here. The first is that, in writing a strategic plan now for the center, when I became permanent director, we reviewed the different scientific themes, if you will, that we were going to, concentrate on. And so one of the scientific themes that I injected into the new strategic plan was an aging and cancer scientific theme. And that ultimately led to the development of the Geriatric Oncology Center of Excellence, which is a research center of excellence that spans across basic science, population science, clinical care delivery, training and education, and clinical trials specifically for older adults. So we have 5 pillars within the center, and it really functions to create bench to bedside translational research and training and education.
Mhm, mhm.
So it became a focus for the investigators. We've issued pilot funds, in the aging and cancer space for projects specifically dedicated to aging and cancer research.
Mhm. So now that you're comprehensive, how does your life change?
Well, I think that this, clearly, demarcates the, high level of productivity, scientifically for the cancer center. And I think that we, see the important, breakthrough discoveries that we're making and bringing them into the clinical setting. And I think we have a very unique opportunity at SKCC because we we were in the process throughout this entire time of developing regional research sites throughout the community, recognized that, the sort of thinking about moving research closer to home, and so building out clinical trials, portfolios in these regional research sites to really enable clinical trial participation close to home throughout all of southeastern Pennsylvania and southern New Jersey. And we have placed clinical trialists in these regional research sites so that we have people who are dedicated and experienced in doing clinical research, but they're in the community. So I think the movement forward, now is to really further extend our capabilities across, all of the regions that we serve, and that is in the clinical research arena and the population science arena, but we also have the potential maybe to even extend the basic science component as well.
Mhm. How many research sites do you have? I forgot that.
So in the community, we currently have 3, and 3 others are under development.
But you also have a lot of sites that are care sites.
There are other care sites, yes. So what we did is we looked at, strategically the geography that we cover and ensure that, we have strategically placed these regional research sites
Mhm, mhm.
with
No,
the opportunity to develop other additional ones, which is why we're going to ultimately go from 3 to 6.
what will happen to what happens next? What happens in the next cycle? How does Thomas Jefferson change?
Well, I think there's a number of things. So I think, this piece specifically about really, enhancing our research footprint, across the entire enterprise is going to be a major thrust. Certainly, I'm going to continue to push the agenda with regards to, the aging and cancer theme, both at the bench and into the population and into clinical trials. I'd like to see, dedicated clinical trials that specifically address questions for older adults, not only in terms of their treatment, but also their survivorship. So that'll be important, pieces to push forward. Um, so those will be some of, I think, the important next steps, for us. There is, I mean, it is public knowledge that we have a letter of intent with Lehigh Valley the Lehigh Valley Medical Center Health System. And so that encompasses a number of different care delivery sites, and also a hospital system that is well versed in doing clinical research in the community. And so that merger has not been completed at this point. As I said, we only have a letter of intent, which is public knowledge. But should in fact that merger take place, that will open up an additional geography for SKCC. And we'll be working closely with the team at Lehigh Valley, as I said, who's already, very experienced in terms of clinical research and high quality, safe cancer care. So that would extend our footprint and extend it even deeper into other rural populations. We serve a number of rural populations in South Jersey, but this will extend our footprint even further.
Well, you can't have this conversation without mentioning Joe Simone, and Joe Simone's one of his maxims is leadership does matter. Is that you led this process? How'd you do it? What was your leadership, I guess, strategy to this?
Sure, sure. Well, I think there's a number of things. The first is that, it's important to listen, and I thought that that was really, I didn't have to be the smartest person in the room. I didn't have to have all the answers, but I really needed to understand the skill sets of all of the people, in the leadership of the center, as well as the scientists, throughout the consortium, and understand how to really get all of that skill, functioning together in one direction. And I think that was really the key is recognizing for the people around me that everybody brings important talent to the table, and that really getting people to work at their peak level together was really going to be the formula for success.
Yeah, but 14 months, you don't have much time for taking wrong
We had a
turn.
very short runway for the grant submission, and we had a very short runway for the site visit. And we didn't have that luxury of time, as you pointed out. So, I think that this is where the teamwork, the hard work, the time, and getting people to believe, that we could get this done. And I think that that was really important, part of this. I mean, Paul, this is the classic Philadelphia story. This is, we were underdogs. No one at the beginning would have thought that this was likely going to happen. And I think that the code words are leadership and team. That's what it was about. And so, I constantly would say to everyone in the room, this is our time, and the time is now, and we have no time to waste. We got to get this done. And we knew that we had the science. We knew that we had the skills. We knew that we had done the work, right? So it wasn't like there were these gaping holes in terms of the actual, science in the center, the research. It was pulling it all together and ensuring that everyone on the team, fully bought into the mission and really understood that we could get this done. And there was a bit of a learning curve for everybody to really believe. At the beginning, people were like, look, if we can just keep things at pace and, get redesignated, that'll be great. And it's a new director, it's a short time frame. So, we're going to do our best. And then as time went on, we started to realize that, we have a great story to tell. And we have the right people to tell it and to do it. So I think it was a function of just getting everybody, really to understand that and believe that.
Oh, fascinating. Um, is there, what actually, now that you're a comprehensive cancer center director, what keeps you up at nights? What worries you the most right now?
I would say probably, that the issues that we faced with regards to funding, are really a concern. I think that, recognizing that the pay lines for R01s, are going in the wrong direction, recognizing, that the funding for the cancer centers, has been decreased, recognizing that the components, that were going to be funded, are on hold. So I think that I think it's related um, to those risks and the recognition that it's going to be a tougher environment, right? For cancer centers at the current time. And I think that, that worries me because, we've already seen a pool of, scientists, move from the cancer centers into industry. It's hard to get, the first, R01s, and I worry that that's only going to become more difficult.
How's the money?
So Jefferson has been, incredibly supportive of cancer research, of the cancer center, of continuing to grow and develop the cancer center. And so the package that was given to me as director was extremely generous. In addition to that, through the consortium, Drexel is supporting, cancer research. And then additionally, we have put in place a funds flow model that specifically enhances the dollars that flow into the cancer center specifically for research projects.
So you're okay on that, you think?
Well, we can always use more money, Paul. And so we have our teams out working, hard to write grants, to work with donors and to grow the enterprise. So we can always use more dollars for research.
Is there anything I forgot to ask?
Um, well, I think the other things that I would, the other thing I would comment on is just the um, unique position that, Sidney Kimmel Cancer Center plays in the region that we serve. So the, academic medical center is in Center City, which really puts us at, sort of the heart of the city, an underserved, um, highly underserved community, with a lot of challenges with social determinants of health and all the things that you can, imagine. And yet despite that, we are delivering on the, promise to lower the cancer burden and doing that through the science at the bench, bringing that out into the clinic, bringing treatments that are, first in human, that to underserved communities that never had access to these treatments. And then, recognizing that, part of our responsibility then extends out into this vast array of communities, which are very diverse. And so, we created a service line 7 or 8 years ago to really operationalize cancer care delivery and be able to bring that highest quality, safest cancer care to everybody's doorstep. Because part of my mantra has been that the care cannot be disparate based upon which door you enter the Sidney Kimmel Cancer Center. It has to be the same. And people have to have access to everything that the Cancer Center has available, whether it's the latest and greatest treatment, the latest and greatest technology, the supportive services. And I think that, because as center director, I have oversight of both the service line and the research arm of the Cancer Center, and they're fused. It creates one mission, and it enables us to really do things, in a very translational way. We're bringing information from our community back to the bench. It's informing what the scientists are thinking about, and we're taking those discoveries and we're going to extend them beyond, our footprint at the university hub through these different regional research sites. So this is what we're supposed to do. This is how we're going to lower the cancer burden, and this is the first in class, move to get this work done. And
Mhm.
we think that we have now the infrastructure in place to be able to do this effectively. We're servicing the community in an exceptional way through our community outreach and engagement efforts. So, we're making a huge impact. We've put, a van on the road. There's another van that's going to be, coming. We're getting out there, and we're getting into places where people don't traditionally have access to healthcare because they don't choose to, because they have not been connected. We're going to places where people work to get them screened. So we're doing things to connect to the community. And I think that we have now the structure in place to connect the entire research continuum from the bench all the way to the community and back. I think
Mhm.
that's really what's going to make us unique.
Mhm. Well,
And that's
thank
what
you.
we're supposed to do, right? That's why we're here. The call from the NCI is to lower the cancer burden in the area that you serve. I take that literally and seriously.
Mhm. How concerned are you about the atmosphere, political atmosphere, and the pushback to any moves for equity?
I believe that we need to do the right thing for people. And I believe that everybody deserves the highest quality, safest cancer care. So, at least to my best of my capabilities, I'm going to try and ensure that that's the case. Does the potential, changes that, have occurred in the country, do they worry me? You bet. Am I directly influenced by that in the region that I work currently? No. But does it worry me because of, what we've seen in other states, around the country, and the potential, risks that it may pose to care? Absolutely.
Mhm. Well, thank you very much, and congratulations again.
Yeah, I appreciate you taking the time to do this. It's been an interesting ride.
Yes.
As one of the administrators at Jefferson said to me when I started, they said, I'm going to give you one piece of advice. I said, good, what's that? She said, you have a tiger by the tail. Don't let go.